Hi, my name is Megan Applewhite, and I am a general surgeon and bioethicist. It's a pleasure and an honor to talk to you today beside my esteemed colleagues at the Department of Defense Medical Ethics Center. In this session, we will discuss the physician-patient relationship and how having an understanding of both the medical aspects of care as well as the human perspective of our patients is critical in answering challenging ethical problems that arise in the care of patients. Much of the information I'll discuss today is based on the American Medical Association Code of Medical Ethics. This is certainly a resource that's available for your review if you're interested in more details on the topic. So, to begin the talk on the clinical encounter, a physician's relationship with their patient is carried out in the clinical encounter, which is a fundamentally moral activity in which a patient who is well or ill is seen by a physician whose job it is to either prevent or alleviate suffering. This relationship is grounded in trust and is generally entered upon under explicit agreement of both parties, except in a few circumstances. And examples of these would be when emergency care is needed and an agreement to enter the relationship is implicit, when a physician provides appropriate care for an incarcerated patient in keeping with the ethical guidance on a court-initiated treatment, and when a physician examines a patient in the context of an independent medical examination in keeping with ethics guidance. The duty to care in a physician's relationship is carried out within this clinical encounter. They have an ethical obligation to care for patients regardless of their race, gender, LGBTQ status, infectious disease status, or other personal or social characteristics that are not relevant to their care. Does this mean that the physicians do never have a right to decline engagement in a physician-patient relationship? No, there are certainly situations in which physicians are able to limit their relationship. This would include when patients are asking for assistance outside of the scope of the practicing physician, or when the patient is seeking service that is not supported by evidence-based medicine, or when a physician conscientiously objects to the care of a patient, which means that the patient's request would be violating a deeply held personal, religious, or moral belief of the physician. If this is the case, the physician is obligated to transition care to another provider who is able to comply with and engage in therapeutic relationship with the patient if the help that they seek is within the standard of care. Finally, the physician also should engage if they cannot deliver safe care due to lack of resources, or if the patient is abusive or threatening to the physician, staff, or other patients. Unless, again, this is an emergency situation and the patient requires care and they're the only physician around. So getting to patient rights and responsibilities. In the physician-patient relationship, both parties have rights and responsibilities. Rights that may seem obvious are respect, dignity, and a safe space to receive and understand medical care. They're entitled to timely responses to their needs, the ability to access physicians to discuss risks, benefits, costs, and alternatives to propose therapies, to obtain copies of their medical records, and to have protection of their information in accordance with privacy laws. But in addition to these, they're also entitled to the objective clinical recommendations of their physician, as well as to access second opinions when possible. Recognizing that in military medicine that this can be a limited possibility at times depending on availability of physicians. They also have the right to be informed of any potential conflicts of interest of their physician and continuity of care that varied providers communicate with one another, and if care is being ceased for some reason, that the patient be given timely notification to make arrangements. Finally, if they have a right to a chaperone if they wish, and there are some practices that offer a chaperone to every single patient they see, regardless of why they're seeing them. There are other practices that will routinely offer a chaperone for a gynecologic exam or a breast exam or a prostate exam. But in any event, if the patient wishes at any time, they are entitled to a chaperone, and this is something that should be available to them. These rights do come with responsibilities, however. So in return, it's expected that patients are truthful with their physicians, that they cooperate and adhere to agreed upon treatment plans, and be honest if they've elected not to or have been unable to adhere for any reason. They're expected to meet the financial costs of medical care and to appreciate and respect the limited resources, including the time and supplies involved with clinical encounters and procedures. They should be educated about and expect to follow through on healthy lifestyle choices, recognizing that this is the best long-term plan for wellness and also prevents undue burden on the system as time goes on. They're expected to refrain from behavior that places the public good at risk, including engagement in vaccinations and other activities that decrease the risk of infectious disease spread. Patients are responsible for their conduct, and they are obligated to refrain from disruptive, abusive, or aggressive behavior, and also have an ethical obligation in any event to report any witnessed illegal or unethical behaviors by their physicians to the appropriate governing body. As with any relationship, the other side also has responsibilities. So a physician's primary responsibility is the delivery of thoughtful, quality care and respecting their patients in the process. Among the many ways that they can do this is by staying current with the standards of care in the literature, communicating effectively, knowing their own personal data and outcomes in order to continually improve over time. They should also have high expectations of the quality of their staff to optimize how well patients are cared for, both in and outside of the exam room, so that patients feel comfortable approaching their physician and feel comfortable with the care that they're getting. Because so frequently what patients experience when going to the doctor is wildly outside of what happens directly with the clinical encounter. It's the parking structure, it's the checking in at the front desk, it's what station is on the television outside, and it's how they're treated when they're roomed and when they're sent home. And finally, it is a physician's obligation to participate in quality improvement initiatives with the effort to ever improve how well we're able to take care of people. So here we'll talk about the exercise of conscience. So physicians are expected to respect the autonomy of patients and to uphold ethical norms of the profession. However, physicians aren't robots, and they aren't programmed to receive input and deliver output as order. They're moral agents in their own right. They're not defined exclusively by their profession. And so at times, a physician may find him or herself in a situation where carrying out the wishes of a patient is in direct conflict with their deeply held beliefs. This can create a tension in the physician-patient relationship and is one of the situations in which it's reasonable to transition care to another provider in order to uphold the personal integrity of both members of the relationship. The AMA Code of Ethics states directly that physicians should have considerable latitude to practice in accord with well-considered, deeply held beliefs that are central to their self-identities. However, they also note that this freedom is not unlimited. Physicians are expected to perform care in emergencies, to honor informed decisions, and to have respect for those individuals who refuse life-sustaining treatment. They need to have a basic respect for civil liberties, and they need to they need to limit the practice of exercise of conscience exclusively to their deeply held beliefs that are thought to mold the identity of themselves and of themselves as a physician and as a human being. It's important not to extrapolate exercise of conscience out to peripheral political or religious beliefs that you may or may not decide to buy into at any given time. That in fact, the idea behind exercise of conscience is to really exclusively be held to deeply held beliefs that really mold your identity. Considering exercise of conscience is not inconsequential, so it's really important to think through the following things, as many people are affected by this. Consider how significantly, if the physician does go through with refusing care, that it'll compromise their personal integrity. It's important to be clear in the relationship with the patient about personal convictions when it's possible. Actions should not discriminate against or unduly burden an individual patient or population of patients or affect patient or public trust. This can't be understated. It's important to be mindful of the burden of transfer to other physicians, as it is the obligation of the physician to refer to a capable and available physician in order to carry out the wishes of the patient if they are within the standard of care. It's important to uphold standards of informed consent, including options to which that physician may have moral objections, as it is a reasonable alternative in any given situation. And finally, it's important to refer to another physician or provider capable of caring for that patient and respecting their autonomous choices. So one extension of the physician-patient relationship is who the patient is. The idea of treating oneself or a family member can pose real challenges, especially when there are very few physicians in a small area. It may become necessary at times, and the complications can be that personal feelings may cloud objective evaluation. The physician may feel or may be less likely to ask specific questions that, although necessary, are sensitive and uncomfortable given their personal relationship. They may feel obligated to treat a family member if asked, even if it's outside their scope of practice. So treatment of self or family should be generally avoided, except in a few cases. Number one, emergency settings with no other qualified individual around. Number two, short-term minor problems. And in these two cases, appropriate responsibilities are carried along. So one must document and treat and everything, document the treatment that is transpired and communicate with the primary care physician. They also must accept responsibility of possible negative consequences or fallout of the treatment that may compromise their relationship with that family member. And finally, it is important to avoid sensitive and intimate care of minors. One should take extreme measures to find another individual who is not, in fact, related or in close relationship with the patient in that situation. So one extension of the physician-patient relationship otherwise, but particularly as it pertains to military medicine, is in the care of detainees. So we will talk in detail about detainees in a future talk on the ethical care of special populations and vulnerable groups. But in accordance with the DoD instruction regarding the medical program support for detainee operations, healthcare personnel will exclusively maintain a professional provider-patient treatment with detainees for the purposes of evaluating, protecting, and improving their physical and mental health. Although certainly conflicts of interest and dual loyalties can arise in the care of detainees. So this brings us to the concept of dual loyalty. So this is a principle within the conflict of interest called dual loyalty, wherein one individual has two separate interests that potentially conflict with one another. This can come into play in military medicine and ethics when the mission or one's obligation to the military seemingly conflicts with their patient relationship. To refer back to the insightful words of Professor Giordano in his initial lecture, in military medicine, there is a duty to protect the patient as a service member. This is to say, service in the context of profession. I'll use an example that the esteemed Professor Procaccino has made familiar. There's a situation where there's an outbreak of syphilis on the base, and in an effort to limit the spread of the infectious disease, the physician asks a private who he's slept with. He says, "Oh yeah, Lindsay, Carly, Sarah, and oh yeah, the commander's wife." In this scenario, the physician's obligation to function within the structure of the ranks and also maintain patient privacy is called into question because it would put at risk their ability to control the spread of an infectious disease and, as such, the public health. But reporting the findings would potentially create significant other problems, including the likelihood that other privates would be unlikely to disclose who they have potentially infected out of concern for retaliation. This is just one of many scenarios, in addition to the care of detainees, wherein dual loyalty plays a challenging role for military physicians in the bigger picture of conflict of interest. So here we'll talk about bigger conflict of interest as it may apply more appropriately to civilian physicians, but when a physician is employed by a company whose relationship with the patient, who may be employed by a company and whose relationship with the patient is complicated by an obligation to assess health for this third party, but also be an examining physician. So being impartial to both parties while having a financial relationship with one and a physician-patient relationship with the other has the potential to create distrust or concern for potentially ungrounded findings. So this, quote, relationship is usually limited to a single exam or a counter, but nonetheless, it's critical that the physician disclose their relationship with the third party before examining the patient, make clear that their role is to assess health or disability independently of this third party, and make clear that they will protect personal health information within the standards of the profession. Finally, they are required to inform patients of incidental findings so that if necessary, the patient can seek further care, even if this doesn't directly relate to the reason for the exam initially. Conflicts of interest will come into play more specifically when we talk about doing consultations and trying to comb out any conflicting interests within that setting. So here, is where we'll make a transition into talking about ethics committees and consultations. So this is a very practical part of this talk. The practice of medicine is so complex that even when every effort is made to maintain a respectful and functional patient-physician relationship, there are value-laden decisions that will arise in which an ethics consult is requested or an ethics committee support is requested to help support a thoughtful, informed, and deliberate decision to clarify this complicated issue. So, as such, involvement of ethics committee is not necessarily a failing of the patient-physician relationship. In fact, it can work to enhance the relationship by increasing understanding on both sides and ideally result in better care for the individual. Perhaps the most important part of laying the groundwork for ethics consultation is that ethics consultants are not decision makers. This can be really tricky to navigate when a physician is the consultant because the physician understands the medical aspects of the care and perhaps what's going on a very dynamic level at the bedside. But when when they take on the role of an ethics consultant, they no longer are required to make medical decisions and in fact are encouraged only to focus on the ethical component of care and to sort of boil down to what is the ethics question at hand and how can we advise and facilitate to help resolve it. So they're not decision makers. They ask clarifying questions and they're detached from these decisions and as such are able to promote respect for the values, needs, and interests of all participants in an effort to come to a consensus. By working to understand the fundamental ethical question involved, an otherwise very complex problem can be worked through. So as a final part of this talk, I'll describe one such technique that is easy to use, that's reproducible and practical for ethics consultants to work through difficult questions, and it's called the 4-box method. So the 4-box method is a good tool to use when challenging questions come up, just to know what kinds of questions to ask and how to start sorting through the tangled knot of a complicated question. So how to initiate resolution in many ways is emotionally and morally charged for different stakeholders in the situation. So one way to address and break down complex ethics problems is described by Dr. Johnson and colleagues in their book, Clinical Ethics. This approach is intended to be very practical, meant for physicians and others who take care of patients on the ground level to be able to make sense and clarity from challenging ethics consults. And it's organized by 4 topics. Number 1, medical indications. This supports the principles of autonomy and beneficence, as well as non-maleficence. Secondly, patient preference. This supports respect for autonomy. Thirdly, quality of life, principles of non-maleficence and respect for autonomy, and contextual features, which sheds lights on the principles of justice and fairness in the consult. So these 4 are separated out into 4 different quadrants and then placed into a grid. So organization is helpful in order to sort of triage your thoughts and be able to think through these questions. So arranging these in a grid will structure your decision making, and going through box by box will clarify these value-laden topics at play and work to facilitate a resolution. So I'll go through each box and the types of questions that may be asked in order to make this more familiar. So in medical indications, one may ask, what is the patient's medical problem? So very clearly, what is the problem? Is it acute? Is it chronic? Is it critical? Is it reversible, emergent, terminal? Let's get a better picture of what setting are we in? What are the goals of current treatment? What is the medical team trying to achieve with what the patient is having for treatment at the moment? In what circumstances are these medical treatments not indicated? So what could arise such that what is happening right now at the bedside would no longer be needed? In sum, how can this patient be benefited by medical and nursing care and avoid harm? So this is addressing beneficence and non-maleficence. In the patient preference box, we ask questions related to autonomy. So has the patient been informed of the benefits and risks of recommendations, understood and given consent? Now, this can also be extrapolated to address surrogate decision makers as well if the patient, in fact, is unable to make their own decisions. Does the patient have capacity? Is the patient legally competent? If yes, what preferences are they stating? If no, has the patient expressed prior preferences? Who is the appropriate surrogate decision maker? So in the case that the patient is at the moment able to make their own decisions, in the case that this should change and they're no longer able to make decisions for themselves, who is it that they would want to make decisions for them? Has this been identified in advance directive? And look, this is the question that sort of would prompt you looking into finding out what kind of documentation they have in terms of advanced directives and durable powers of attorney and any other sort of players that would help going forward. Finally, is the patient unwilling or unable to cooperate with medical treatment and medical treatment at question? And if so, why? So this sort of, with the first box, the medical indications giving you a state of the union of exactly what's going on with their treatment. What are the goals? How can we do best for them and avoid harm? The second box of patient preferences really being like, what does the patient want? What is it that the patient will, at the end of the day, be grateful for their surrogate decision maker having voiced for them, or what in fact, in the end of the day, is their goal of care? Going down to quality of life, what are the prospects with or without treatment for a return to an acceptable quality of life? So what physical, mental, and social deficits might the patient experience even if treatment succeeds? And so this is kind of setting realistic expectations. So on what grounds can anyone judge what quality of life would be undesirable for a patient who can't express such judgment? I think many people would presume to say, having perhaps, a bilateral blindness, would be something that they wouldn't want to, live with. And so a patient certainly wouldn't want that either, right? On the other hand, if you have a patient who doesn't necessarily value their sight and all they would want is to be able to hold their grandchild and smell roses, then that is a reasonable quality of life for them to pursue. So understanding really very firmly what the quality of life is of the patient, what their preferences would be in the top right box, and then sort of checking ourselves to say, am I capable of understanding, given the patient preferences, what to them is a good quality of life? Sort of taking out my biases that might prejudice my evaluation of quality of life. What ethical issues arise concerning enhancing a patient's quality of life? And this could relate to issues of justice, limited resources, and other such topics. And do quality of life assessments raise any questions that might contribute to a change of treatment plan, such as foregoing life-sustaining treatment? Finally, are there plans to provide pain relief and comfort after a decision has been made to forego life-sustaining interventions? So understanding quality of life, what the current quality of life is, what potentially intervening or maintaining the current level of care will afford them in terms of quality of life. What quality of life is it that they would accept, and then getting them there in a way that is compassionate. Finally, we'll talk about contextual features. So are there professional or business interests that might create a conflict of interest in the care of the patient? And we talked about this when we discussed physicians who work for insurance companies who may do physical exams in that capacity, dual loyalties, just trying to understand sort of where the physician is with things and whether or not the question is difficult to answer or the treatment is difficult to dictate, or why a resolution hasn't come up because potentially there is a conflict of interest. So asking this question becomes really important. Are there parties outside the clinician and the patient, such as family members, who have a legitimate interest in the decisions? What are the limits imposed on patient confidentiality by the legitimate interests of the third parties? And is this something that the patient is okay with? Are there financial factors or institutional affiliations that may create conflicts of interest in clinical decisions? And are there religious factors or legal issues that may influence clinical decisions? Are there considerations of clinical research, medical education, or public health and safety that affect these clinical decisions? So these are a lot of questions and a lot of words, but in fact, it's relatively simple, and it can be broken down even more by sort of backing out to the grid and saying, all right, above the double line and below the double line. Above the double line, the majority of decisions made here, or the majority of answers, can be gotten by the clinicians. Any disagreements between parties that occur above the line are typically the responsibility of a failure of communication or fear and pain limiting decision making, a lack of trust, or values that are different from traditional medicine. Solely identifying that any one of these problems exists is a huge step toward being able to resolve the problem. So asking the questions, determining where the conflict is or where the lack of clarity lies, and then further sort of detailing it in this way and breaking it down can be really helpful. And then we look below the double line, and this is largely dictated by patient preference. So these topics are typically not a part of the clinical workup, but they're essential to understanding clinical ethics cases. Factors external to the medical problem at hand that fundamentally influence decision making. And so to go back to the introduction of my talk, this is really where sort of the human side of taking care of patients comes together with the medical aspects of taking care of patients. One can be an excellent clinician and have very good clinical judgment, but if they know nothing of what happens below the line, if they don't ask the questions, of patient preferences above the line, if they don't understand what a quality of life means to the patient or get a sense of the contextual features of what is in and around the ethical challenge, it's really hard to tackle complex ethical problems. So I put this out there as an excellent tool to use that is capable of simplifying really complicated problems that you may encounter while taking care of patients and having ethical consults that come up. So this is, in the end, the role of the ethics consult service. This is meant to highlight that it's of critical importance that many teams are involved and that everyone talks together, that the ethics consultant is in fact not a decision maker, but rather one who asks important questions, clarifies, educates, and then advises. I hope you found it helpful, and I hope that it works for you, and I am happy to give you my citations in order to allow you to read more on the topics if you wish. And it was my pleasure to talk to you, and I'd be happy to provide more information if needed.